Now we are going on to the last case of the day, and it will be presented by Dr. Mahinder. One must remember that the presentation can vary from one to the other place and one to the other examiner, but importantly the same issues which we addressed in the first three cases will be probably reinforced. We will try to take some fresh issues also. This is one case which is almost always kept in every exam, so everybody should be very, very focused into understanding how we go about presenting the history and how do we examine. This case will be presented by Dr. Mahinder, who made the first presentation. So I'll pass it on to Dr. Mahinder, please.
Good evening, everybody. I am Dr. Mahinder Singh. I am presenting a case of 60-year-old postmenopausal lady Sahiba. She is a laborer by occupation and she is a resident of Muzaffarnagar, UP. She presented in surgical OPD with chief complaint of ulcerated lump in right breast 3 years back. She was apparently normal before 3 years when she noticed a small swelling in upper outer part of right breast, which was insidious in onset. Initially it was 2 into 2 centimeter. It progressed within a span of 2 years to attend the whole breast, increase up to size of whole breast. It ulcerated 1 year back. Initially the ulcer was 1 into 1 centimeter. It slowly progressed and attained the size of 6 into 6 centimeter. She consulted to a doctor and she attended the sub-surgeon OPD and chemotherapy was started. And after the starting of drug, the size of lump and ulcer has been reduced. There is history of destruction of nipple areola complex, and there is history of pain over swelling since 1 year. It is developing in character, initial on and off, and it relieved by taking oral medication. But after the initiation of chemotherapy, the pain has been regressed. There is no history. There is history of discharge, bleeding discharge. There is only one episode of bleeding discharge. There is no history of fever. There is history of weight loss. Although is not able to quantify, but according to her, there is loosening of clothes. There is history of loss of appetite. Initially, she was taking 4 chapatis, but for last 1 year, she was taking only 2 chapatis. But after taking chemotherapy, the appetite has again improved. There is no history suggestive of distant metastasis. Past history. There is no history of any chronic comorbid illness. There is no history of oral contraceptive pills or hormone replacement therapy intake in past. There is no history of radiation to breast in adolescence. Personal history. She is having normal dietary habit. She is non-vegetarian. She is not an alcoholic, not a smoker. Bladder bowel habit is normal. Sleep pattern is normal. Menstrual history. She attended menarche at the age of 13 years. Cycles were regular, 28 days, and bleeding was normal in amount and normal in duration. And she attended menopause 5 years back. Age at first childbirth was 16 years, and she is having 7 live issues. All child were adequately breastfed. Family history. There is no history of breast, abdominal, or ovarian malignancy in family. Treatment history. She has received 5 cycles of chemotherapy, after which swelling has regressed.
Anything in the history, Abhinav? Salim? Yes. Shamishta?
First child. Age of first child.
Age of first child was 16.
Why is that important? You had mentioned, but I'm asking.
The differentiation of the ductal epithelium cells it becomes terminally differentiated at whenever the mother starts lactating the baby. So, if it's a differentiated, the chances of cancer is less.
So it would decrease the exposure of endogenous estrogen exposure to the body.
Simple. Simple answer to a simple question. So the time lapse between menarche and the first baby is important, right? And wider the gap, higher the incidence or lower the incidence?
Higher.
And what is the significance of miscarriages?
So it's significant, very lightly induce the risk.
Abhinav?
So it is said that it can increase the unopposed action of estrogen, but subsequently it has not been proven to have
Not substantiated, but if at all it has a role, it is mainly on account of unopposed action of estrogen. How about the oral contraceptive pill, Salim?
Sir, oral contraceptive pill also it causes hyperestrogenemia, so it increases the risk.
What is the present evidence on that?
But
so earlier
present-
oral contraceptive pills had increased amount of estrogen, which was resulting into increased incidence of breast cancer. But now the dose of estrogen in the OCPs have reduced, and there's a contribution into causing breast cancer.
Any other factor which is responsible for no coordination between the two?
So the risk decreases after 10 years of stoppage of OCPs.
Right. Anything else?
Cholesterol content of the OCPs.
No, that they mentioned. Anything else?
Pregnancy will be
OCPs only.
Yeah, progesterone on the pills.
Well, we've discussed it many a time, but anyway, I'll still tell you. The age at which the breast cancer occurs is not usually the age when oral contraceptive pills are taken. So the correlation cannot be established. And the dose is reduced now, that is also a factor. And how about the hormone replacement therapy? You covered that beautifully. I didn't find any lacuna in your history, that's why I'm asking them. Anything else?
please come.
No, about the hormone
Hormone
replacement therapy.
replacement.
Did she receive it?
No sir, there is no history
Is
of
she
hormone.
postmenopausal?
Yes sir, she is postmenopausal.
Please define menopause for us.
Cessation of menstrual flow for at least 1 year.
And-
At the normal age of menopause.
And anything else to that?
History of bilateral oophorectomy or age more than 50 years without menses for more than 12 months. If the age is less than 50 years, I'm sorry, I'll repeat it again. History of bilateral oophorectomy. Second, if the patient has not undergone bilateral oophorectomy, age more than 50 years if she is not having menses. Then age less than 50 years if she is not having menses, and her baseline FSH estradiol levels have to be in the postmenopausal range in the absence of any hormonal supplements.
Ashpal?
So history of bilateral oophorectomy is less than 60 years. Age greater than 60 years, the patient is on hormone replacement therapy with FSH and LH level more than oophorectomy status, and moreover there is cessation of the menstrual cycle for more than 1 year of. But it got debated, sir. Last time the presentation of the held and it was argued.
No, but you can argue on existence of God also.
So they were saying if there is cessation of menstrual cycle for
No, they are not
5
important. What are the guidelines?
The recent NCCN guidelines, they are saying the cessation of menstrual for 1 year. The
See
patient-
dear, NCCN guidelines are the only guidelines based on which cancer is managed these days all over the world. Until such time that you make your own guidelines, like Europeans have made. When you don't have your own guidelines, what are the options? NCCN guidelines. And that 5-year business is out of use because of the same reason. There is something else there. So let's not get confused with what he or they were saying. That's not important. NCCN guidelines, the moment you refer to NCCN guidelines, you're right. They are arrived at with a lot of difficulty. People sit for the whole year. They plan protocol of management of each group. And in each group, there are hundreds of people contributing. So there is no confusion about, there's nothing like 5 years anymore, right? And in any case, if it has to change, again the guidelines have to come. So your answer in the exam should be based on NCCN guidelines. Now your second question would be, if your examiner is not aware of the NCCN guidelines, then you have a serious problem at hand anyway. So it's safer to say sir 5 is also right, but let me move on. Sometimes the best way to move on is, the best way is to agree to disagree later on. But first agree so that you can move on to the next step. Right? That's also an art you must learn. Sometimes you have a problem with the other person's mindset, but that is not your problem. But that day it becomes your problem. So let it flow so that you can talk about the other thing. You should be living to fight another day. Clear? Because when you have to educate them, you will take a lifetime. That's not the day. So just relax. Let's move on. Move on to the...
General physical
And I'm glad you took a very good family history. No family history of any ovarian, breast or abdominal malignancy, which is very good. The other thing is, it's more important to, what is a high risk family history, Mahendra?
Sir, any history of breast cancer or ovarian cancer in first degree relative, like mother, sister and daughter.
Let's make it better.
So any history of breast cancer, colorectal, pancreatic or ovarian cancer in the first degree relatives would prove to be a high risk.
Occurring at
Less than
50 years.
Young age of onset.
A younger age. Now, otherwise it may not be. Let's move on. Examination. Now we can examine this patient here also, but you will describe the findings first.
General physical examination. Patient was examined after taking well-informed consent in well-lit room after adequate exposure and adequate privacy. He is conscious, cooperative, well-oriented to time, place, person. Performance distance 90 by Karnofsky. Nutrition status is poor on account of pallor. BMI is 20 kg per meter square. Hydration status is adequate. There is a green cannula present in right forearm. Right. There is loss of hair. Patient is affected to touch, and she is having pallor, and there is no icterus, no cyanosis, no clubbing, no pedal edema, no generalized lymphadenopathy. Pulse rate is 88 per minute in right radial artery, regular in rhythm, normal in volume, no specific character. BP is 120 by 80 mm of Hg, right arm supine position, and respiration rate is 14 per minute, thoracoabdominal regular. Local examination.
Flawless. Let's move on.
Inspection, sir. Local
Need
examination.
help for this row.
Inspection was done by sitting position, arm by the side. Examination of left breast and left axilla is normal. On inspection of right breast, there is right breast is slightly elevated. Right breast, it is slightly enlarged in compared to left breast, and there is destruction of left nipple. There is destruction of right nipple areola complex, and symmetry is distorted.
Where is the right nipple areola complex? You can show your
Destruction.
pen without touching.
So,
Head away.
destruction.
You can stay away and show it. It's destroyed. You can bring it from this side and take it. Yes. More clear now. Okay.
There is a visible ulcer present in upper outer quadrant around 4 into 2 centimeter. Appears to be healing, and margins are well defined and regular. Edges are sloping and covered with pale granulation tissue. There is a visible fullness present in upper outer quadrant, extending
You've already seen, no? So don't touch it. You can
extending into axilla and base of armpit. And there is multiple hyperpigmented area and hyperkeratotic area present all around the ulcer. Multiple hyperkeratotic and hyperpigmented area present all over the ulcer.
all around the ulcer.
All over the ulcer. Yes.
Okay.
Palpation. Palpation, there is no local rise of temperature, there is no tenderness. There is a lump. Lump is present which is irregular in shape. It is 20 centimeter in horizontal, vertical dimension, 15 centimeter horizontal dimension, present in upper outer quadrant and extending into central quadrant and into anterior axilla. And superiorly it is extending up to base of armpit. Margins are well defined except inferior margin where induration is present. It is firm in consistency, and there is cystic area present in hyperpigmented skin, and the lump is not fixed to underlying structure. Axilla, there is a single fixed 2 into 2 centimeter lymph node present in anterior axillary fold, which appears to be fixed.
Demonstrate fixity. How did you look for fixity to the pectoralis major? We're going step by step.
Yes, sir.
And
Now, patient in sitting position. I will explain the procedure. माता जी आप लोग चेक करके देखना, ठीक है? Arm at the hip, waist. हाथ यहाँ रखिए. हाथ यहाँ रखिए, ये आदमी यहाँ रखिए. First, I will confirm that pectoralis major is not pectoralis muscle is not contracted. It is relaxed. Then I will check for mobility.
where is the right hand? On the back of the patient. So
Okay,
that the
sir.
patient is not tilted away.
Yes, sir.
What I wanted you to do.
So, now along the direction.
That's right, but always stabilize the patient.
Okay, sir.
The head and neck, the same thing. You missed it. Don't let the patient go sway.
sir.
Now go. At right angles? Yes.
Yes,
It's
sir.
mobile.
Yes, sir. Mobile.
Now
I will ask the patient to
make the
push
muscle
waist
taut.
muscle control. माता जी जोड़ लगाइए यहाँ पर.
Confirm that it is
Yes,
taut.
I will confirm it is taut. Then I will again check the mobility.
Slightly restricted.
Not so most.
It is not even in relation with the pectoralis major.
Yes, sir.
So it won't be affected by anything happening to pectoralis major. It's more in relation with serratus.
Serratus anterior, sir. I also checked for serratus anterior.
How do you check?
And sir, there is visible discharge when I palpating the lung.
No, that's right.
Purulent
How do you
discharge.
look for serratus anterior? You want her to stand or sit?
Sit.
She is listening to you.
Okay. माता जी यहाँ हाथ रखिए. यहाँ हाथ रखिए. First, I will check when my muscle is not contracted, and same direction, sir.
Okay.
Then I will ask the patient to push her hand. धक्का लगाइए माता जी यहाँ पर.
Feel the muscle again. Already. इनको नीचे दबाइए कंधे को.
Contracted muscle. Muscle is contracted.
Not fixed to serratus.
Yes, sir.
I can see that. That's okay. And look for the. How do you look for the axillary lymph nodes?
So now first I will look for anterior axillary lymph node, which is against the anterior axillary fold. So with the pulp of my fingers, I will fill in anterior axillary fold by holding the fold and by.
See, look what he has done. He has put the right hand on his right
For
forearm,
stabilizing.
so that his left hand is free, and this stabilizes the patient. This hand, your hand goes further up. Yes. Now you get the complete counter traction.
Okay, sir. Then I will look in center region for central group of lymph node. Then I will look for apical lymph node, which are more proximal to central group of lymph node.
So you are applying pressure from above,
Yes,
also,
sir.
so that you can get a counter traction. How do you look for the supraclavicular?
I will stand behind the patient. अम्मा यहाँ से थोड़ा खुदना पड़ेगा आपको.
Okay. That's it. छोड़ दो माता. She was already okay.
I will ask the patient.
Where are the arms? हाथ आगे रखिए.
हाथ आगे रखिए माता जी. I will ask the patient to shrug the shoulder to relax the deep fascia. माता जी थोड़ा कंधे ऊपर कीजिएगा.
How will that relax your deep fascia? Make it loose only. Now examine the supraclavicular. How do you look for the infraclavicular? Do it on the normal side.
So one hand in the supraclavicular region.
The other hand under the
Infraclavicular region.
supported on your forearm.
Yes, sir.
Yes. This one goes above. The other one goes in.
Yes, sir. Both
That one goes in. That one goes from below. That's how you get the infraclavicular. Otherwise, how would you get it? From below into the axilla, dear. Yes.
From axilla, sir.
अभी तो होगा ना. अब ऊपर से और नीचे से you are able to bimanually try to meet your fingers.
Okay, sir.
That's where the nodes are. Not given anywhere, no? That's why you're
Yes, sir.
confused. I demonstrated in the railway hospital.
Yes,
see.
sir. But in some book it is written, sir, one hand in infraclavicular region and one hand in
You
supraclavicular region.
can't insulate. Try to
Yes,
do
sir.
that infraclavicular. Because with your hand you can go right up to the rib,
Yes, sir.
first rib, and you can go to the infraclavicular fossa. But you want to push from above so that you are able to feel it.
Okay, sir.
That is how it is done. Okay. Proceed
Yes, sir. Examination of lateral group.
loudly.
Examination of lateral group. Now the patient arm is supported on
The
my
arms
forearm
have changed.
and supported lateral aspect, and we will palpate again the shaft of humerus.
Yes. In the bicipital group.
Yes, sir.
Okay.
Palpation of posterior group. You have to stand on behind the
Doing
patient.
them.
Behind
Left
the
hand
patient.
takes care of the right hand. Yes. And right hand goes behind.
Yes, sir.
Now you go along over the
Posterior
legs on the
axillary
dorsal and feel for the posterior
Posterior axillary
fold.
fold.
Right?
Yes, sir.
What else did you examine?
Examination of bilateral supraclavicular fossa normal. Examination of spine, cranium, pelvis, ribs, long bore appears to be normal. Examination of other system, abdomen. There is soft, no agenomegally, no free fluid. Examination of respiratory system, bilateral equal breath sound, no tenderness. And I would like to do digital rectal examination and vaginal examination.
Why?
I would like to look out for any simultaneous malignancy or any metastatic deposit in pouch of Douglas, or any fluid in pouch of Douglas.
Can she have Kuchenberg's tumor?
Now, for permission examinations, I would like for any ovarian tumor or any Kuchenberg.
Can she have
No,
Kuchenberg's?
she won't have because it is common in premenopausal. Ovary should be active.
Remain alert to the question.
Yes, sir.
I know you know the answer, but you should know it. Now, I would like to see the lump again and your description of it. Just demonstrate again. Is it a lump which is ulcerated or it's an ulcer you were describing?
Sir, lump is ulcerated. My atana.
Torch. Okay.
Yes, sir. There is a lump
Please
present.
don't touch it. Just
Yes, sir.
describe it.
Sir, lump is present, which is extending laterally up to anterior fold of axilla, superiorly up to base of armpit, and inferiorly, sir, inferiorly it is extending, but I am not able to feel inferior margin, and laterally it is extending up to.
It's a diffuse lump.
Yes, sir. But
And the whole breast.
sir, but I can palpate the superior, lateral, and medial margin, but inferior margin
So there is breast there, breast tissue. So you're not able to isolate it or
Yes,
find
sir.
out clearly. But there's something that has happened. Nipple areolar complex is destroyed and the whole thing is pulled up.
Yes, sir.
So where do you think is the disease? Naturally there.
Yes, sir.
The ligaments of Cooper and everything are involved in that region. So it has got pulled up. So the disease is basically involving the superior quadrant.
Yes, sir. Upper outer
Superior quadrant,
Superior.
both. Because now there is no upper outer because where is your nipple?
nipple is destroyed.
So how would the quadrant remain?
Yes, sir.
The reference point is gone.
Superior.
The whole of the superior breast is involved. It's just the inferior part which remains. Involved and destroyed.
Yes, sir.
You agree?
Yes, sir.
Now, even if you do the test on falling forward, does it fall forward?
No, sir.
So that would mean it is fixed to chest wall.
So the breast is contracted and fibrous. So
This test does not hold relevance because the entire breast is fibrous and is
I'm
full.
saying, so the description would be, that's exactly the question. Now, are these satellite nodules? Put your pen on the satellite or you want me to come there?
so the
1, 2, 3, 4. What are these?
so they are hyperkeratotic and hyper.
What is a satellite nodule?
So satellite nodules are present away from the lump.
Yeah, the diseases involving so much of area, they will also be hyperkeratotic. They will also have more of pigmentation. Otherwise, how do you explain these nodules? What are these nodules actually due to?
Involvement of skin.
What are the satellite nodules? Now, the moral of the story is quickly agree and move on. They look like satellite nodules, however, they are hyperkeratotic and there is an ulcer in the center. You agreed and you not agreed. No, you may disagree, provided you are tested for agreeing. So don't try to unnecessarily waste your time on that. Because if you look at this nodule all around, this is here. I mean, I'll put it 1 o'clock, 5 o'clock, 9 o'clock. These are nodules and the rest is hyperkeratotic. And the whole thing is not areola.
It's a areola is distracted.
So this is all pigmented area.
Yes, sir.
And these are nodules. So hypokeratotic surrounding skin with nodules,
Yes, sir.
which are probably satellite nodules. Although here it doesn't make a difference, it will be considered involvement of skin anyway. What are the features of involvement of skin? Ulceration, satellite nodules, pause orange. Is there any pause orange here?
No, sir.
Look carefully, try to bring the skin together.
My atana.
There you are. So actually, things get missed out if you are totally looking at a glaring
Yes,
aspect.
sir.
There are satellite nodules, there is pause orange in the lower portion, and there is an ulceration, and the whole area has got fibrosed and fixed to the chest. Actually, it has got fixed deeper inside. And testing with pec major is out because pec major is going here. It's actually going away from it, right?
Yes, sir.
Right, move on. Any question? How about the contralateral axilla?
No more, sir.
Palpate it again.
माइक को जाना पड़ेगा
Just lift it up. Yes, carry on doing it.
हाथ क्या रखिएगा
Now, why are you changing it here? Put the hand. Where is the hand going to be put? You did it correctly on the other side.
ये हाथ उस पे ले लेफ्ट वाले पे ले और राइट हैंड से पकड़
Yes? There's no axilla? Now, this is how he was doing it. I know the position is a little awkward. And there is a node right here, but actually I don't have to even go far. Sometimes you go very high because you're looking for nodes much higher. It's better to bring your finger, this is the node. Spend some time doing it now.
Yes.
Or I'll fix it for you and make you see that. Gently take it to the tip, okay?
Yes, sir.
This is the tail. And here, bring your finger. Hold along the chest wall. Take your time. This going like this, Mahendra. Hand should go like this.
In the absence of a lump in the breast,
Contralateral breast.
and with the presence of axillary node, that is considered to be metastatic.
You have to look at it carefully, even to the extent of going in like this.
So it's present in entry axillary movement.
But why it gets missed, I am telling you why. Because we go higher.
Okay, sir.
And if you go along the anterior fold, you'll feel. What would be the significance we have understood? The disease being so advanced, you must look for it and anticipate that it would be there. And that is our whole purpose. Any questions based on history and examination? The history was good, examination was good, yeah.
That means is the lump will not fall forward on stooping, so it chest wall
It's
is has
true, it's not in the front actually. A lump which is in the front would fall forward. Lump is on the side,
Yes, sir.
and that's the worry. Your lump is extending into the almost to the axilla. So where does it fall? And I personally feel that it would be difficult to appreciate fixated to serratus anterior, which is chest wall.
Yes, sir.
It's not a freely mobile lump anyway. I mean, when you were moving it, I could see that. But I don't want to hurt the patient because to me, it still would be the same stage. We'll try to find out. It will be T4, let's see A or B. A is likely, but B, and therefore it will become C if both are involved. Okay. Any other questions? Yes.
So the examination of the infracarpal nose, that is, so we examine from the axilla. The one hand is in the axilla.
Yeah, one hand is actually you're going, it's a little cumbersome job. Basically, this is which side she has a lump.
Right.
So let's look at the right side. Now, axilla is actually nothing but a triangular, a pyramidal kind of a space, no? And breast is here. This is how the lymphatics go, right? Now, axillary vein is the upper limit of axillary dissection, but above that also sometimes the nodes are there. We normally are not supposed to dissect above the axillary vein. This is the vein. Somewhere here is the cleft. That's the costoclavicle ligament, which is the last, is the medial limit of axillary dissection. Halsted ligament or costoclavicle ligament, which is this only, right? Now the vein is coming out here, and first rib is here. You know that subclavian becomes the axillary vein. You want to palpate these nodes. How do you do that? One hand from above, one hand from below. In any case, you are feeling the apical nodes. The hand above pushes the contents down, so it becomes easy to get. Now, where do you stand and do it is the issue. So you will go behind and get into the superior part, and the other hand is to go inside. So both of them have to meet. Impression? Summarize your case and give us a diagnosis.
60-year-old postmenopausal lady presenting with an ulcerative lump in right breast since 3 months. Initially, the lump was 22 centimeter, progressed within 2 years, and 1 year back it was ulcerated. And she consulted to a doctor. Adjuvant chemotherapy was started, and lump has regressed in size. There is history of pain, there is history of bleeding discharge, and there is no so there is no history.
What is the diagnosis?
Diagnosis 60-year-old postmenopausal lady presenting with carcinoma right breast T4B and 2M1.
Why N2?
So there is a single lymph node present which is fixed in anterior fold.
How can we look for the internal memory lymph node?
Internal memory lymph nodes cannot be seen, cannot be palpated. According to your book, they can be percussed. Right? And you percuss in the intercostal space in the parasposternal area. If you find dullness, then lymph nodes are present. I have a suggestion. Take up a hernia patient or any patient and percuss in the parasternal area. You'll find the same dullness that you'll find in any patient. Okay? So finding internal memory nodes is a finding on imaging. It is written in your book, that's why you're asking. Similarly, I think I've discussed it in your class also. Similarly, looking for retrosternal extension of thyroid by percussing on the sternum. And I'd given you a good advice that day, go back home and percuss your own sternum. Then you all have retrosternal extensions of a gland which is not even enlarged. These are tests which have found their relevance in the era gone by. Nobody looks for these things clinically anymore. You agree?
Yes, sir.
Her question was to you, how about internal memory group of lymph nodes?
Yes, sir.
Clinically, can you find them?
No, sir.
If you find it dull, you will call it a positive.
No, sir. We need imaging, sir.
Will it change your management? Will the presence of internal memory nodes change your management?
So it will change the staging of end staging. It will change.
How will it change the end stage?
So it will presence of clinically apparent internal memory lymph node is N2B.
So how would it change your management?
Sir, it will change into locally advanced.
What is it now? N2.
So in this case,
In which case it will change your management? In no case.
Can it change the field of radiation to be
That is seen by imaging. Neither would it change your approach, diagnosis and management. Locally advanced breast carcinoma is, what is the definition? T4 with any N,
either increase in size,
N2 with any T, M0.
either increase in size or fixed insulin. T3.
Why should we waste time? T4 with any N and M0, N2 with any T and M0. So how would it matter? A, B or C? Even D won't matter.
So T3 and 1 is.
Rarely T3 and 1 is included, and that is a large operable breast cancer. But that's not a classical locally advanced breast cancer. You can include, that's not. Clear to all? Right?
Yes, sir.
Now, give us the diagnosis.
60-year-old
60-year-old postmenopausal lady with a
carcinoma right
locally
breast,
advanced breast carcinoma of the right side, stage.
T4B and 2 and 1.
If you are convinced about the node, then only. Otherwise, let's stick to what you were saying earlier. T4B, N2, M0 or MX. We'll work at it. Clinically, with a palpable node on the other side, not a palpable lump on the other side, it becomes M1. Anybody with a doubt? Titiksha? You? Yes? Anuradha?
If a patient has undergone previous surgery for a lump in the breast, and
TX. Next.
then if the lymph nodes are present, then we state that is the TX and X, or do we use the T?
She's saying, if I understand correctly, that primary was treated but no axilla was handled, right?
Yes.
Then the lymph node status can still be N1, N2, but the tumor will be TX. But suppose she has been put on chemotherapy, what is the stage then? What is the clinical classification for Nikhil, for after chemotherapy staging? After neoadjuvant chemotherapy staging?
After neoadjuvant chemotherapy, we prefix the Y before the final stage of the
So we have answered that. TX is when you cannot accurately assess. That is if somebody has received therapy for an irregular period you are not you're not controlling the management. You call it TX. So that means you have to ascertain it at some point of time. You can't live with TX. Right? Let's move on. How do you proceed in this case?
Investigation to confirm my diagnosis. Biopsy has already been done and disease has been confirmed and neoadjuvant has been given.
This you don't have to take into account. You give us your
Investigation to confirm my
don't say that in
diagnosis.
the exam that it has already been done, so about you start as if it is a fresh case.
Investigation to confirm my diagnosis. Investigation to stage the disease. Investigation to treat the patient.
Right.
To confirm my diagnosis, I would like to do bilateral mammography and tissue diagnosis, preferably core-needle biopsy, and investigation to stage my disease, complete hemogram, liver function test, isotope bone scan, CCT chest and abdomen, and to treat the.
Now you will be bothered by your friends who are going to examine you because they are not clear on CT thorax as a mandatory part of NCCN guidelines. So they know it in bits and pieces. But CT thorax is mandatory. CT thorax inclusive of upper abdomen is mandatory in patient with locally enlarged breast carcinoma. Bone scan, isotope bone scan is mandatory, you're right. Everything that you said is correct. But be prepared to deal with it. If they say not needed, so generally recommended, NCCN guidelines recommended. Otherwise, if you say today it's not indicated, that's okay. Tomorrow I won't leave it. Bone scan is mandatory. Metastatic workup is mandatory in all locally advanced breast carcinomas and symptomatic early breast cancers. There is absolutely no doubt. Clear? Let's move on.
Other routine blood investigation.
Treatment. Any question? You can ask. Why core-needle biopsy, not FNAC?
So because it will provide a tissue diagnosis, it will tell about type of tumor, grade of tumor, receptor status of tumor, and differentiate between invasive and in situ cancer.
Very good. That covers up.
Why mammography if you are doing CCT?
Why mammography if you are doing CCT? Imagine this could be a question tomorrow. One of them can ask this kind of question. CT भी करेंगे, mammography भी करेंगे. क्यों? Why do you want? CT has nothing to do with breast. CT is done for metastasis. Mammography is for the breast.
Mammography and MRI.
So why are you doing mammography, bilateral mammography?
To find out the tumor in opposite breast.
And CT doesn't find that out. CT has a different role. But that question can come tomorrow. And you know how to answer. Okay? Then, let's move on. Management now,
Yes, sir,
you've done
management,
everything.
Yes, sir. Neoadjuvant chemotherapy has given 5 cycles has been given.
What drug, what dosage?
So
What is neoadjuvant chemotherapy?
So, neoadjuvant chemotherapy is the therapy that we give before any definitive treatment, which could be surgery, which could be radiation.
Good, excellent. Before any definitive treatment, therapy that is given in neoadjuvant may not be chemotherapy all the time.
Yes, sir.
You can give neoadjuvant radiotherapy also.
Okay, sir.
Given in soft tissue sarcomas, retroperitoneal sarcomas very commonly.
Yes, sir.
Okay?
So we complete the cycle. Cyclophosphamide is
How many cycles?
6 cycles. In neoadjuvant we are usually giving 3 cycles. We have 5 cycles will be completed. And the dose is cyclophosphamide 500 mg per square meter and adriamycin 50 mg per square meter and 5-fluorouracil 500 mg per square meter on every 21st day.
Why 21st day?
Because
Auspicious, I know, but why?
cells need to, the rest of the body cells need to recover.
Rest means cell of the eye, cell of the
Cells,
ear.
bone marrow cells and intestinal cells, rapidly dividing cells.
Can we give hormone along with it?
No, sir, because hormone therapy works on stabilizing, not dividing cells.
Once we give chemotherapy, the chemotherapy needs
I give
actively.
hormone therapy will prevent them from
Chemotherapy
multiplying.
needs actively multiplying
Chemotherapy
cells.
will not act because chemotherapy needs multiplying cells. Chemotherapy needs moving enemy. Hormone therapy makes them still. It cannot see the enemy now. So rapidly multiplying cells is what you are looking for in the management of when you are using chemotherapy, and hormone therapy can make them static. And there is a cell cycle, S phase, and which phase chemotherapy is acting in? In which phase is hormone therapy acting?
Hormone therapy is active on G1 and S phase.
G1 and S.
G1 and S. If you block them, then what happens to M phase?
M phase
There
will
won't
not
be-
come. It
There
will
would be no M
stabilize.
phase. If there is no quarter final, no semi final, there is no final.
Yes, sir.
So therefore you don't give it. Yes. Side effects of adriamycin.
Cardiac toxicity.
Conditions which increase the cardiac toxicity of adriamycin.
Using cyclophosphamide with the drug and using trastuzumab for previous cardiac disease.
Side effects of cyclophosphamide.
Hemorrhagic cystitis and cardiomyopathy.
So you've given your adjuvant chemotherapy. Is she a responder?
Yeah, she's a responder.
What would be a responder to you?
More than 30% decrease in the size of
What is the criteria used for response assessment?
So racist criteria.
What is the RACIS criteria?
response evaluation in criteria in solid tumor.
How much? What is the calculation?
There is complete response, partial response, and stable disease and non-progressive and progressive disease.
Good.
Complete response is more than 30. Complete response is complete.
That
Complete
is
disappearance of
CCR.
tumor.
More than
More than 75. Complete disappearance of tumor.
that is CCR.
And partial response is more than 30% reduction in the size of lump. And non-progressive is there is less than 30% reduction. And progressive is there is more.
See, there is one group that says 50% and less than 50%. More than 50% response responders, less than that non-responders. Progression, non-responders. Stable disease, non-responders. But then between 50 and 75, they also have a group, 75% respond. That is
WHO. That is WHO criteria.
That's a WHO criteria. And you look for CCR, complete clinical response, or pathological complete response, which is assessed in the specimen after histopathology, which is the best marker of outcome. Right? Now, what surgery would you offer?
Modified radical mastectomy.
If it is fixed to the chest wall,
If it is fixed to chest wall, then modified radical mastectomy with resection of chest wall, and if it defect, we can repair.
how big a defect can be repaired without a mesh?
Less than 2 ribs.
Very good. But the mesh would be enough if you go beyond that, or you need some bony support,
We need some bony support like now osteomyelitis flare.
or some plate, cyanoacrylate, for making a plate. Otherwise, it will be a flail flap. You know, it will go in on inspiration, so it can be a problem. And then you follow it up with what is the adjuvant therapy for these patients?
Adjuvant therapies are now post-operative radiation to breast field and axillary field, and so chemotherapy has already been given. And after the radiation therapy, we can give hormone therapy on basis of estrogen receptor status and trastuzumab on basis of HER2 new receptor status.
Can you give hormone therapy to patient with a negative ERPR status?
And the response is very low.
Can you or can you? You cannot. You don't. You don't give it. What are the biological types of breast cancer?
So luminal type A, ERPR positive, HER2 negative. Luminal type B, ERPR positive and HER2 also positive. Luminal type C, which is ERPR negative, HER2 positive. Luminal type D, which is triple negative.
Right? So this is the basis of deciding on therapy. Now, chemotherapy is more effective in ERPR positive or ERPR negative tumors.
In ERPR negative tumor.
So you will accordingly plan it, and she will require radiotherapy also. Any question from anybody? Abhinav, Salim, Manish, Mukesh, anyone of you here? Yes, Titiksha, Shamishta. If I could hear, he can't hear you at all. Speak loudly. When you give second line chemotherapy, I was going to ask you this question.
Second line chemotherapy is now patient is not responding to the
No, you have done a core needle biopsy. Can that help you plan a straight away second line chemotherapy?
we can go for in vitro chemosensitivity.
No?
If the patient is triple negative, then we can switch over to taxane-based therapy.
Yes, triple negative, you can start with taxane-based chemotherapy. If she is not fit for surgery, and if that is an M1 disease, what would be your approach?
The treatment is radiation, sir. I will start with hormone therapy. hormone therapy,
What do you do for the wound? Ulcer, it's fungating.
toilet mastectomy,
What is a toilet mastectomy? Is it a mastectomy done in the toilet?
also removal of fungating mass.
It is also a simple mastectomy. Don't do that mistake. With a clear margin. Clear margin means?
Arterial resection,
What
microscopic.
is arterial resection?
Microscopic and macroscopic link.
No, microscopic freedom will automatically mean macroscopic freedom. Microscopic freedom from disease. R1 is when there is the macroscopic freedom, but microscopically positive. Right?
Yes, sir.
Any questions? More questions?
So if lymph nodes are fixed, then how does it change the treatment?
It becomes a locally advanced disease. You put the patient on neoadjuvant chemotherapy. Sometimes if there is a response, the lymph nodes can become mobile. But the fixity of lymph nodes, why is it such a serious problem? That means there is an extra capsular spread. It has gone out of the capsule, which means the disease is already locally advanced. So you are not going to provide cure in that case, but you will try to clear off the axilla.
So I have read, so we do simple mastectomy and give radiotherapy to the axilla.
Simple mastectomy followed by radiotherapy to the axilla is the second option. If you can do surgical clearance, that's the first option. If you cannot do it, that's a different story. Then you don't have a choice. But what are the indications for giving radiotherapy to the axilla?
So more than 4 lymph node positive, more extra capsular extension and depositing soft tissue.
Got the answer? If there is deposition around, and that you will only know when you have done axillary dissection. Extra capsular spread, angiogenesis, lymphovascular invasion, more than 4 out of 10 nodes being positive, could call for local regional radiotherapy. Right? What are the structures that you preserve during modified radical mastectomy?
Axillary vein and now to status anterior, the thoracodorsal trunk and now to pectoralis major, medial and lateral pectoral nerve.
Now, what are the structures you remove during modified radical mastectomy?
Modify skin involving nipple complex, breast tissue with lymph node present in axilla and lymph node present in axilla, level 1, level 2 and level 3 lymph node and intercostal brachial nerve if it is convenient.
Removal of the breast tissue with nipple-areolar complex with axillary tail of Spence with pectoral fascia and axillary lobe of lymph nodes 1, 2 and 3.
Yeah? You have to remove the fascia, you have to remove the axillary tail of Spence, and you have to remove the level 1, level 2, level 3 lymph nodes. What are level 1, level 2, level 3 lymph nodes? Diksha?
So these are divided according to the pectoralis minor muscle. The group which is lateral to the pectoralis minor is group 1.
Level 1. Behind pectoral minor, level 2, medial to pectoral minor, level 3. How about the rotus group of nodes? They fall into which group?
Interpectoral and level 2 only.
Interpectoral, so they fall into level 2 only. So, nodes behind and in front of pectoral minor are level 2. How about the internal memory group of lymph nodes?
So no need to remove anything.
Tell us the end stage of breast tumor.
And one is
NX.
and zero no nodes, NX nodes cannot be assessed, and
Accurately.
one node cannot be assessed accurately, and one is single ipsilateral
Single ipsilateral mobile.
lymph node, and 2A is divided into N.
Single नहीं कितने ही हो? They are ipsilateral mobile.
Ipsilateral mobile lymph node, N2 is divided into N2A and N2B. N2A is fixed ipsilateral axillary lymph node, and N2B is clinically apparent internal memory lymph node in the absence of axillary lymph node, ipsilateral axillary lymph node. N3A is divided into N3A, N3B, N3C. N3A is intraclavicular lymph node, N3B is internal memory lymph node in the presence of ipsilateral axillary lymph node, and N3C is supraclavicular lymph node.
What is limited supraclavicular dissection and what is oligometastasis? If they won't ask you tomorrow, they will. In patients where we have present, I think I was away and Mukesh had to make that presentation of the multiple primaries, where you clear of the level 4 so-called supraclavicular nodes, provided there are no distant metastasis. It is being done, it is being practiced. They are conducting a trial at Tata Memorial and they are clearing of supraclavicular fossa if there is a node. Because level 3 is now a part of LABC. Earlier level 3, it is N3 now. Earlier this supraclavicular lymph node positivity used to mean M1 disease. It is changed. Since you have included it in locally advanced, so you have to treat it also. Otherwise you are treating it by radiotherapy. If there are supraclavicular lymph nodes, they are treated by radiotherapy. But if you can dissect it, it is found to have some advantage. So we do that limited, and we have done a few cases where we are trying to do level, I call it level 4 of axilla. 3 ends there for limited supraclavicular dissection. Okay. That is in oligometastasis. They are minimal, no distant metastasis, etc. Some metastasis to the bone can be treated by radiotherapy. Surgery is indicated even in metastatic breast cancer. There are many studies which show that modified radical mastectomy in metastatic breast cancer improves survival. I am doing routinely modified radical mastectomy in all these patients unless the nodes cannot be dissected, they are fixed. If the nodes are fixed like this, he was asking, we don't leave it there if it is fixed to axillary vein, otherwise we can clear it from with the soft tissue. If it is fixed to axillary vein, we leave a clip there for the radiologist, radiotherapist to know where is the disease that is like. We can treat it by surgery or by radiotherapy.
So what is local regional recurrence and what is its management?
That's a good question. What is locoregional recurrence?
Locoregional present in the
No, locoregional recurrence, LRR.
Locoregional recurrence present in the tumor area.
Yes.
Recurrence in tumor area. Tumor bed.
No. Yes, can you
It
complete?
mean recurrence in the tumor bed. It can be recurrence in the flap of the tumor. Could be axillary.
No. Locoregional recurrence means recurrence in the chest wall, in the ipsilateral axilla, and ipsilateral supraclavicular fossa. It's a very specific term. LRR stands for recurrence at the primary tumor site, that is chest wall, supraclavicular fossa, and ipsilateral axillary. Axilla.
And its management?
The management of LRR could be surgery or chemotherapy or hormone therapy. Now, if there is, this is the case for doing a good metastatic workup. If there are no distant metastases, the management is surgery oblique radiotherapy locally. Now, surgery is better because symptomatically patient feels better. There is no ulceration later on, fungating, wounds don't happen, the nerve involvement is minimal, the chest wall can be free. So you can go for surgery and follow it up with radiotherapy. That's a better option. If the recurrence is isolated, you can manage it. But if the patient has metastatic disease, then you don't go for aggressive surgery. I mean, treatment should not become worse than the disease. That is the basic bottom line in treatment of cancers. Any other question? Yes, just.
So in neoadjuvant chemotherapy when we give, so how do we decide the number of cycles before doing the definitive treatment?
The answer to that, that's another very nice question. I mean, that clearly shows that somebody is understanding what is going on. The total cycles are 6 to 8. You can give 4 before, 4 after, 3 before, 3 after, or you can give all 6 or 8 at one go. It has been tried and it has been studied in trials that sequencing of chemotherapy, radiotherapy, surgery does not change the overall survival. The advantages of neoadjuvant chemotherapy are, number one, it can downsize the tumor to a level where you can still do breast conservation or get a clear margin at least. And the other advantage is it gives you an in vivo chemosensitivity test. The third advantage is it takes care of the micrometastasis, right? This you all agree? Therefore, what we practice is 3 cycles of neoadjuvant chemotherapy, 3 weekly, follow it up with modified radical mastectomy, and the specimen goes for assessment. It gives you an intermediate endpoint, look for pathological complete response. If the patient has, if the tumor has responded completely, if there is PCR, which is pathological complete response, the overall outcome is considered to be better. PCR is a surrogate marker of outcome in breast cancer. So it helps you study that. Otherwise, it does not matter you give 6 or 3 or 4 or 8. How long do you give the hormone therapy, tamoxifen versus What would she qualify for? Tamoxifen or aromatase inhibitors?
Aromatase inhibitors, sir.
Why?
She is a postmenopausal lady, and the estrogen, the main source is extra ovarian. So the anastrozole, they act on aromatase inhibitor, act on aromatase hormone, which will change, convert
Enzyme.
aromatase enzyme, which will convert androstenedione to estrone.
So actually speaking, but tomorrow you cannot answer this because they won't know. Again, there is the problem. They would say we give tamoxifen and we are happy. Agree. But say this point, because there is somebody who can ask. Navneet will understand. Now, if you put the patient on aromatase inhibitors, what is the risk at her age? Bone mineral density being
Bone
reduced,
mineral density.
pathological fractures. See, tamoxifen is ideal for premenopausal women, and aromatase inhibitors are ideal for postmenopausal women. Tamoxifen has side effect of producing endometrial hyperplasia and carcinoma, and aromatase inhibitors have a risk of producing bone mineral density reduction and pathological fractures. Right? Now, the benefit of giving tamoxifen in premenopausal is clearly understood because the source is ovarian. In postmenopausal, the source of tamoxifen is peripheral conversion, where aromatase enzymes are relevant. So to block that is useful. Okay? Any other question?
What are the boundaries of the accelerated section in modified radical
The
method?
limits of, what was your question?
So oncotype DX and ABRT.
No, 1 minute. We'll take that question first. No, we'll take this first because he's asked. The
Boundary
boundaries of axillary dissection.
superiorly is axillary vein, inferior aspect of axillary vein, inferior is angular vein, and medial is costoclavicular ligament, and lateral is thoracodorsal trunk.
Depth. Subscapularis. You're fine. What is angular vein?
Angular vein, it's come from chest wall and joined to thoracodorsal vein to form subscapular vein.
Yeah, that's right. That's absolutely correct. Now your question. Oncotype DX is relevant in early breast cancers. It has nothing to do with bad cancers. Oncotype DX is a kit to find out who amongst ER/PR positive patients will respond to chemotherapy so that you can spare chemotherapy to non-responders. It's a kit which contains multiple 21?
21 gene essays.
It's a 21 gene assay which would help you find out the patients who need
Benefit from chemotherapy.
so that you can avoid it in those patients who are not going to respond. Any other question?
About ABRT, sir.
EBRT.
ABRT.
Accelerated partial, no, APBI, no? Accelerated partial beam irradiation. ABRT. Accelerated partial beam irradiation is not a level 1 evidence to support its use. How does it function? I taught you the other day.
So in the accelerated partial breast irradiation, the total dose of the radiotherapy is reduced. It is only the 38 grays of the radiotherapy, and it is given over 10 days. In this, the doses are hyperfractionated, and in the 1 day, the doses are given in 2 fractions, and 5 days over a week. So on that basis, it is given. But the studies have proven that it is not. Studies have not given the level 1 evidence for its effect.
Not yet established. It only is useful on the left side because you want to protect the heart from exposure to radiation. Naturally, it gives you limited field. It is focused onto that, like IMRT. What is intensity modulated radiotherapy? You modulate and you take it through a prism and you focus it on the side. So that there is no dissipation and there is no collateral damage. I can be 100% sure tomorrow you won't have this problem. They won't discuss this. That's a good question. APBI, not ABRT. EBRT is external beam radiation. IMRT is intensity modulated radiotherapy. APBI is accelerated partial beam irradiation. When you're answering a question in theory, write all this and highlight it with one screen, then yellow, then brown, or whatever color you fancy, or pink usually.
One is an IURT,
Intraoperative radiotherapy. We put that also and do it with a black pen. So there is no effect. Intraoperative radiotherapy is usually in cavitatory surgeries, where you have colonic, prostatic, bladder, even in breast. But it is given during surgery to create a field, and it is computer generated. Naturally, because computer has to do the job, everybody moves out. Radiations are given on the table in an open field, naturally they act directly. Any other question? There is nothing like inoperable LABC. First of all, there is a term called LOBC, large operable breast cancer, which may be treated by neoadjuvant chemotherapy, and you can do breast conservation. This is the group where you can do. This is the T3N1M0 kind of group. It is the others are all locally advanced. Is the term operable and resectable are used wrongly. Resectable is the tumor, operable is the patient. Any patient who is fit for anesthesia is operable, but any tumor that you can get an R0 resection is resectable. Okay. Now, if, like I said, you give anesthesia and cut hair, that also is an operable case. Resectable means you resect it with a clear margin. Now, large operable breast cancer is a large cancer, but it's still operable, which means you can do an upfront modified radical mastectomy to what I am switching on gradually, because I observe that we get a better outcome with the tumor out. But by and large, if you are planning breast conservation, we are doing breast conservation following neoadjuvant chemotherapy, where tumors have actually reduced in size and we can get a clear margin. So that is large operable breast cancer. And there is nothing like large inoperable breast cancer. One is large operable breast cancer, which is one of the groups of locally advanced. Rest is all locally advanced.
Prognostic index.
What is NPI? Nottingham Prognostic Index.
It is called ductal carcinoma in situ. It will take into account the size of tumor, size of DCIS, and microcalcification, and age of the patient.
Very correct. Something else is missing.
So in the Nottingham Prognostic Index, 3 factors are included: size, nodal status, and the grade of the tumor. On the basis of these 3 factors, we include the tumor as 0.2 into the size plus grade plus the lymph nodes, number of the lymph nodes involved. Then we divide it into the 6 groups on the basis of the prognosis.
Clear? So NPI is used for prognostication of breast cancer. And you use for grading the Scarlet Bloom Richardson criteria,
BRs.
and you actually will find out the differentiation and the number of mitotic bodies, blah blah, etc. And you do that. But it's